Medical students, today you find my favorite nerve in the entire body, or at least you try to find it. It is called the descendens hypoglossy, or the superior limb of the ansa cervicalis, a delicate, delicate nerve lying in the anterior wall of the carotid sheath between the carotid vessels and the internal jugular veins. So knowing that it is my favorite, I would encourage you not to cut it right away.
Why is it your favorite?
I don't know why it's my favorite. Because it's just so beautiful and it's just so small. There are other smaller ones I don't like as much, but you'll see it, you'll love it too when you see it. Everybody loves it. There are two kinds of bones in the body. Most of the bones of the body are formed during fetal life as little tiny cartilaginous versions of themselves. And these bones are then, or these little cartilaginous representations, are then turned into bone by a development of something called an ossification center, a little site where the cartilage becomes first calcified, then destroyed and replaced by bone. In any bone that has a cartilaginous precursor is called a cartilage bone, and the process by which that is turned into actual bone is called endochondral ossification. There are some bones in the body, fewer in number, many fewer in number, which never have a cartilaginous precursor, but instead are laid down as sort of connective tissue sheaths, which then ossify directly. That connective tissue just becomes ossified with deposition of whatever, I can't even remember that chemical that makes bone. So those bones are called membrane bones because they never had a cartilaginous precursor, and the process by which they are turned into bone is called intramembranous ossification. The skull, every bone you've looked at, ribs, sternum, hip bone, they've all been cartilage bones. The skull is a mixture of both cartilage bone and membrane bone. Here is a depiction of the skull. And for purposes of discussion, it is divided into two parts. The part which houses your brain is called, colloquially and actually professionally too, the brain case. But in fact, its proper name is the neurocranium. Sometimes you will hear people refer to the brain case as the cranium, but that is incorrect because the word cranium really means the entire skull. It's really synonymous with skull. But, people do what they do. The face, as indicated here, the part that surrounds your mouth, nasal cavities, and the side walls and lower part of your orbit, is technically called the viscerocranium or splanchno-cranium. You hardly ever hear that last word. Or, as most everybody else in the world calls it, the face. This is a schematic drawing of a skull, indicating the regions which are laid down first in cartilage and the regions which are laid down first in sheets of connective tissue which ossify directly. In other words, all the area in blue is going to undergo a process of endochondral ossification, and all the area in gray is going to undergo a process of intramembranous ossification. It is essentially only the base of the brain case, the base of the neurocranium, which is laid down in cartilage. All of the side walls and roof of your brain case and all of your face are laid down first as in membrane and become membrane bones. This is a top-down view. If you put yourself in the position where the developing brain is located and look down onto this cartilaginous floor of the brain case, this is more or less what it looks like. It's obviously still schematic. I only have labeled a couple of things here, the foramen magnum, which is a hole in that cartilage to allow the neural tube to pass through. So that orients you, the nasal capsule up in front, which is going to surround the developing organs of smell and nasal cavities, and a depression in the middle of this, which is where the pituitary gland sits, but the other word for pituitary is hypophysis, so it's called the hypophyseal fossa. So those are more for orientation. The aortic capsule is just a word I thought people should probably know. It is the part of the cartilage which is formed around your developing inner ear, your cochlea and semicircular canals. This, like other cartilage bones, is destroyed at a variety of different sites and replaced by bone. And these sites, as I mentioned earlier, are called ossification centers. These are the ossification centers of the base of the skull. I do not ask the medical students to know the names of all of these ossification centers. Dave, do you ask the dental students to know them? I'm surprised, because you're such a mean guy, I figured for sure you would. Well, he says he's softened up in his old age, and he's not going to make the dental students learn the names of them. I do want the medical students to know the names of the midline ossification centers. So around the foramen magnum, there are 4 ossification centers, and they all contribute to the adult occipital bone, and their name indicates as much. There's one in front of the foramen magnum called basioccipital, and one behind it called supraoccipital, and then 2 out to the side called exoccipital. There is in the autocapsular ossification center, which will form the petrous portion of the temporal bone. Then behind the hypophyseal fossa is a center that will contribute to the adult sphenoid bone. It's called the basisphenoid ossification center. The one in front of the hypophyseal fossa, in front of where the pituitary gland, is called the presphenoid ossification center. I mentioned, just for completeness, ones that you don't have to know the names of. Out to the sides of the pituitary fossa are alisphenoid ossification centers, which contribute to the inferior surface of the wing of the sphenoid bone, greater wing of the sphenoid bone, and then sort of at this oblique extension of the cartilaginous base are the orbitosphenoid ossification centers, which contribute to the lesser wings of the sphenoid bone. And the sphenoid bone also has a membranous component to it as well, as does the temporal bone, has a big membranous component, and the occipital bone too. Then in this thing, which is going to become the bony nasal septum, is the mesoethmoid center, and then these lateral ethmoid centers, which you don't have to know, become the lateral nasal, the part of the ethmoid bone that forms the lateral nasal wall. So the centers which I would like medical students to know are the midline centers, supraoccipital, behind the foramen magnum, basioccipital in front of it, basisphenoid behind the hypophyseal fossa. This is obviously portrayed as an adult skull, even though the skull doesn't look like this when these things are just forming. Presphenoid center in front of the hypophyseal fossa, and then the mesoethmoid center way at the front that will become the bony nasal septum. So these ossification centers form as little tiny areas where cartilage is destroyed and bone forms. And I'm showing this again, and then they get bigger. They destroy cartilage at the periphery and expand in size. That's all this is meant to indicate to you, and I've just labeled the larger versions of these same ossification centers as they've grown over time. And when they do, they compress the original cartilage of the base into narrow zones between themselves. And I mentioned more or less in passing when we talked about radiology of the pelvis, that when you have a cartilaginous junction between 2 bony regions, that's called a synchondrosis. So all of these little narrow zones of cartilage between the ossification centers are called synchondroses. That's plural, synchondroses. And again, there's many names given to them, but the only ones I would like the medical students to know are the midline synchondroses. This one here, between the basioccipital and basisphenoid center, is called logically the sphenooccipital synchondrosis. Between the presphenoid and basisphenoid center, logically the midsphenoid synchondrosis. And between the mesoethmoid ossification center and the presphenoid center, the sphenoethmoid synchondrosis. These are where growth in the base of the skull, longitudinal growth in the base of the skull, will occur. And one of these, the sphenooccipital synchondrosis, actually stays as a cartilaginous junction between the basal part of the sphenoid bone and the basal part of the occipital bone. Stays as a cartilaginous junction there until you are through growing, until puberty, until the end of puberty. And it is responsible almost for the entire growth in the length of the base of your skull throughout your childhood, throughout childhood. These others tend to fuse. That means the bone starts to bridge across them and destroy the cartilage of the synchondrosis and fuse the centers with one another so that the presphenoid center and the basisphenoid center rupture through, that's not the, rupture is the wrong word, but it suffices, through this midsphenoid synchondrosis and fuse with one another shortly after you're born. And the sphenoid ethmoid center is bridged by bone and stops growing, stops being a major growth area early in your first year of life, early in childhood. I don't remember when, I don't care when. Early in childhood, but early. Unlike the spheno-occipital synchondrosis, which exists throughout your entire childhood and adolescent life for growth in the base, length of the base of the skull. The spheno-occipital synchondrosis is so large, I just said this thing here, so early childhood is the answer. All right. The spheno-occipital synchondrosis is so large that in a child, a plain skull film of a child, you see this zone of cartilage there. This is so, I show you this, so if you ever see a plain film of a child, you don't say, oh my God, they fractured the base of their skull. They're not fractured the base of their skull. That is the cartilage of the spheno-occipital synchondrosis. It gets narrower as you get older. I'll be bringing into lab a fetal skull, a skull of a 6 or 7 year old child, and then a diseased skull. But even in the 6 or 7 year old, you can clearly see the spheno-occipital synchondrosis. It's a little narrower relative to the skull, but it's very obvious, or the site of it. Now, this is for the anthropology students in the room, but if all of those who wish to be generally educated, you can, or if you don't wish to, you can just surf the web, as he's probably doing now, or you can pay attention to this. This is a human skull, this is a chimpanzee skull. Well, they have quite a few similarities, but they're not identical. Among the non-identical things about them is the face of a chimpanzee skull is projected, is prognathic, is placed in front of the front part of the orbits, whereas in humans it's tucked in under the orbits. All right? Another difference is the roundedness of the cranial vault. The cranial vault of a human is there's a forehead and we have a much rounder cranial vault. Chimps have a much flatter cranial vault. And finally, although it's not very obvious in this picture at all, here's our occipital condyle, and our foramen magnum points straight inferiorly, whereas a chimpanzee, you can't see it here, but the foramen magnum and occipital condyles point sort of postero-inferiorly, because their vertebral column meets their skull at an angle, 45-degree angle or so. So years and years ago, when I was a young student, people would debate about how many different genetic changes an ancestor of humans had to undergo to account for these differences. And this was resolved, actually, by a fellow who was on my dissertation committee. His name was not Rats, but he worked on rats. His name was Eloy de Bruhl. And what he did was he took a rat skull, which has all of the differences between a chimp and a human, but has them highly exaggerated. Here's a rat's face, and it is completely in front of the brain case. It's not tucked in at all underneath the brain case. Here's a rat's occipital condyle and foramen magnum. They point straight backwards. There is no any inclination. There's any attempt to bring it under the brain case. And the roof of their brain case is perfectly flat. So they're like they are the primitive condition that even chimps have evolved from. What he did was surgically, because he couldn't gain access to he took the rat pups when they're born. They're just like they're like prenatal humans. I mean, they're like human fetuses when they're born, because what's the name for that?
Metamorphosis? Is that metamorphosis? Is that what you're talking about?
No. When you're born, but you're still a baby.
Neonate?
No.
Yeah.
No, that's the opposite. Precocial's the opposite.
Altricial's the opposite.
Altricial.
You got all these what's the name for this? Come on, Paul.
Altricial, is that what you want?
Is that what you're looking for?
Altricial or...
I'm not really sure where you're going.
I'm going with, what's the name when you are born and you're still a fetus when you're born?
Altricial.
Altricial? I thought Bryce said that was the opposite.
No. Precocial was the
Altricial. Thank you. All right. So listen, now we all learned something here, right? So they're altricial. They're born, almost at what we would call a fetal stage. Anyway, you can get these things. You can't gain access to these midline synchondroses here, the sphenoethmoid or the midsphenoid, but you can gain access to the spheno-occipital synchondrosis. So he surgically destroyed the spheno-occipital synchondrosis of a bunch of infant rats. All right? And by God, it changed the shape of their skulls. Here is before and after he destroyed the spheno-occipital synchondrosis, and here's an X-ray, plain film X-ray of before and after. It changed the shape of their skulls, and in fact, if you draw, in red is represented the way the skull shape changed. In black is the original rat-shaped skull. All right. The way it changed it was by tucking in ever so slightly the face underneath the brain case, giving a rounded contour to the brain case, taking the foramen magnum and occipital condyles and tucking them into the brain case, under the brain case a little bit, and creating a little kink here, a little bend in the base of the skull. Let me just go back to this. Here's an X-ray. This has a completely flat skull base, whereas there's a little angulation. It goes up here and then bends and then goes across there, right at that site. These things are all of the changes in rat life that distinguish humans from chimpanzees. He did it by destroying the spheno-occipital synchondrosis. Fact is, I told you our spheno-occipital synchondrosis grows long throughout our childhoods and adolescence. But what makes us unique in terms of these synchondroses is that we are the only primate in which the mid-sphenoid synchondrosis fuses immediately after birth. And in fact, it's really at the site of the mid-sphenoid synchondrosis that the bend in the base of the skull occurs. So, bottom line, by early and earlier premature fusion, early and earlier fusion of the mid-sphenoid synchondrosis in some ape that became human-like, all of the changes that I mentioned can be brought about. So you don't need 100 different genetic changes. You need something that controls the rate of fusion of the mid-sphenoid synchondrosis, and if you just fuse it early, you will produce a human from a chimpanzee, something that some of you could hope for one day. All right. All right. So the growth of the cartilaginous base of the skull is essentially genetically determined. Very little of what's going on around that base of the skull, in any of the soft tissues or around the base of the skull, has any impact on the growth of the base of the skull. It is genetically determined. On the other hand, bones, intramembranous bones of the skull, which are most of them, have their growth determined almost entirely by what's happening in the underlying or attached soft tissues. So membrane bone growth is not genetically determined. It's determined by mechanical pressures from the attached and underlying soft tissues. That's very different from the cartilage bone of the base of the skull. Here are the fundamental ways in which tissues of the body can grow. All right? There is what's called the general body growth curve. The general body growth curve is what applies to things like your muscles, your guts, your heart, that's pretty much your lungs, just sort of generalized soft tissues of the body. This applies to all of them. You're born right here. They are growing pretty rapidly when you are born, but then they start to slow down as you get to be about 2, and they get slower, and their growth gets slower and slower, and grows hardly at all. It grows a little, but in relative terms, not much between 8 and the time you reach puberty, and then there's a pubertal growth spurt, and then it grows very rapidly again, and then they finally reach their adult size in this person around 20 years old. This is the typical pattern of the way children grow in overall size and body tissue organs, soft tissue organs. This is the growth of the central nervous system tissue, the brain and the eyeball, which is just an extension of the brain. They have a very different kind of growth pattern than general soft tissues. They have a very rapid phase of growth after birth, and that rapid growth continues on for 5 or 6 years, and then they start to trail off and reach 90% of their adult size actually by about 6. So your brain and your eyeballs are, by the age of 6, about 90% of what they're going to be, whereas your general body is 40% of what it's going to be. This reason here, this is the reason that children are cute. Children have, and puppies too, this is true of all mammals, puppies and cats and things like that, are considered cute because they have big brains and small faces. Then when they get to be like you, they become ugly. Faces relative to the brain. So it's really just known that if you ask people to judge whether something's attractive or not, the bigger the brain relative to its face is a major factor in determining whether they think something's attractive. All right. So this is just for the sake of completeness. Lymphoid tissues are the only tissues that actually reach a greater absolute size in your early life than they will have in your adult life. The thymus being probably the best example of that, but I probably applies to lymph nodes as well. They maximize out just before puberty, and then puberty they start to shrink in size and get down to their adult size at 20, but their adult size in terms of thymuses is almost nothing. Lymph nodes not so bad. And then this rounds it out with the reproductive system, which is sort of it behaves a little bit like general body soft tissues like muscles and guts and lungs and things like that, except it doesn't have such a rapid growth period immediately after birth. It's really quite slow throughout from birth all the way until you reach puberty, and then instead of having just a modest jump at puberty, your reproductive organs have a major jump at puberty to reach their adult size. And I forgot one other. Okay. So it is the general. Now I have to use a blackboard here. The fact that membrane bones respond to the pressures on them, exerted on them by soft tissues in their vicinity or attached to them, accounts for several things, which is, number one, if you have a child born with microcephaly, meaning their brain was not properly developed, they do not have a small brain inside a normally shaped brain case. They have a small brain and a small brain case over it, because the brain case, the side walls, back walls, and roof of your brain case are responding to the pressure of the growing brain. No growing brain, no big brain case. Similarly, if you have an enlarged brain, because you have hydrocephalus, which is pressure building up within the ventricles of your brain, and your brain is ballooning out, you get an immense brain case in response to the pressures of that ballooning out brain. And it also applies to things of your face as well, and this was brought home to me very much by not a condition, that's probably an exaggeration, by a trait that one of my children had. Now, this child is now 36 years old, so it's not an issue anymore. But when she was a little girl, we felt, my wife and I felt, that her lower jaw, her mandible, was not growing in proportion to the rest of her face. She had a marked overbite. And we felt that this was going to get worse and worse, and that eventually she'd have to undergo a surgery not dissimilar from the one that is going to be shown in a few days, or in the next video shows a child who has a marked overbite, not underbite, and the surgery that had to be done to correct that, which involved, in our daughter's case, cutting the mandible and shifting part of the mandible relative to one another. So I was pretty upset about this, to be honest with you. And we went to the orthodontist, and I said, "Oh my God, is she going to have this surgery? How long? When should we do it?" And he says, "Jack, you're crazy. There's a really easy way to treat this." And this is the way he treated it, and it's an illustration of how soft tissue pressures determine the growth of membrane bones. I'm going to draw a mandible looking down onto the top of the mandible. These are its condyles. This is the body of the mandible, and this is where I always say the dental students, now you know why I don't teach dental anatomy. These are all the teeth. The soft tissues that are controlling, or at least play a major role in growth of the mandible, are the tongue, which sits here behind your mandible, posterior to the front of it, and, I don't know what, I'll use yellow for this, and your lips, here's your lower lip, which sits in front of it. This is what this fellow, this orthodontist did. He created for her something called a lip bumper. It was a wire. What color should wire be here? Huh? Blue. All right. It was a wire that wrapped around her last tooth, whichever one that was at this particular age and time, and then ran forward here and in between her mandible and her lower lip. So this wire pushed her lower lip away from her mandible. And by pushing her lower lip away from her mandible, allowed the growth of the mandible, which is responding to essentially two pressures, the tongue, which is causing it to get longer, and the pressure of the lip, which is causing it to get shorter. It eliminated the pressure of the lower lip on the front of the mandible. Now you would think this is ridiculous. How could this possibly work? How could these pressures be of a magnitude to have an effect? It worked absolutely and completely perfectly. She wore this thing at night for about a year, and just by allowing the tongue then to be the sole force, pushing the mandible forward and removing the backwards pressure from the lower lip, her jaw grew into what I'd consider to be a beautiful proportion and a beautiful young woman. So the idea is that no one would have predicted who didn't know that. I mean, I was an anatomist. There's no way I knew that soft tissues control growth of membrane bone, but I never would have predicted that very subtle difference of simply removing the pressure from the lower lip can have such a dramatic impact on the way the mandible grows. So that's what brought home to me.
How old was she? How old?
I think she was about 7 or 8 when we started this, and maybe she did it for a year or two. So maybe you won't remember any actual science behind what I just said, but you may keep this image in your mind of how dramatically soft tissue forces control the growth of intramembranous bone. Now, here is a picture of a newborn skull, but when it's still, I'm just showing in gray the areas of the newborn skull which are formed in membrane, and in blue, as usual, the areas of the skull which are preformed in cartilage. And I put here, just to remind you, the ex-occipital ossification center, which one on either side of the foramen magnum and the cartilage at the base of the skull, and the supraoccipital center, I just haven't labeled it there, which is behind the foramen magnum. But all these other ossification centers are the ones that are forming in some of the ones, not all of them, but some of the ones which are forming in the membrane bone of the skull, or in the membranes that will become the bone of the skull. And there is an ossification center on either side here near the back top of the skull, which is called the parietal ossification center, will become the parietal bone. There is one here at the back of the skull in the middle. There it is again. That's called the interparietal center. It's actually going to become the membranous part of the occipital bone, and it will fuse with the supraoccipital center. I've not labeled this one here, which is going to become the greater wing of the sphenoid, but I just put it in there for the sense of completeness. I have labeled the squamous temporal center, which is going to become the squamous portion of the temporal bone, the petrous portion being a cartilage bone. And so cartilage bones merge with membrane bones to form complete bones of the skull in many cases. And then up in the front here on either side of your forehead are the two frontal ossification centers. Just like the ones in cartilage, which expand and start to encroach on one another, are the ones in the ossification centers in the membrane bones of your brain case start to grow and expand, converting more and more connective tissue in fetus. This is in the fetus. More and more connective tissue into bone, and eventually they squeeze that connective tissue into narrow zones, just like in endochondral ossification. We had synchondroses, which were narrow zones of cartilage between two bony centers. Here we have these narrow zones of connective tissue between bony ossification centers are not called synchondroses. They are, in this region in the skull, called sutures. They're called sutures. So as these ossification centers approach one another, you get created as a side effect these zones of connective tissue called sutures. And the one between the parietal center and the squamous portion of the temporal bone is called the squamosal suture. The one between the interparietal center that will become part of the occipital bone and the parietal is called the lambdoid suture, and they're shown in two views here, side and top. The one between the two parietal bones is called the sagittal suture. The one which bridges across all the way from side to side between one parietal and the frontal on that side and the other parietal and the frontal on its side, so it spans 4 centers there, is called the coronal suture. It goes completely from side to side between frontals and parietals. And then there is a suture between the two halves of the frontal bone called the metopic suture. Here is the same top view, but expanded to point out that at the zones where, in this case, this would be lambdoid suture here, and sagittal suture there, where the sagittal suture meets the lambdoid suture, is a zone of slightly more connective tissue, which is called a fontanelle, and that's called the posterior lambdoid fontanelle, at the junction of the sagittal suture with the left half and right half of the coronal suture, and the metopic suture is quite a large zone of connective tissue, diamond-shaped or rectangular, depending on how you tilt your head. A large zone of connective tissue called the anterior fontanelle or the bregmatic fontanelle. And let's take a look at what these sutures do during your lifetime, and also some more about the anterior fontanelle in a bit. The sutures actually have a real function during the birth process. Because they are zones of connective tissue between these ossification centers, they allow the bones of your skull to shift relative to one another. And that shifting is very important in the birth process because the woman's pelvic outlet is generally not big enough to admit the brain case of, or the head of, a fetus which is about to be born. So these bones, as the head is being squeezed by the pelvic outlet of the woman, the bones start to shift relative to one another, using these sutures as sort of a joint between them. And when the child is born, if you had a child yourself, or you've seen a newborn for one reason, you'll note that the bones often overlap one another. The two parietal bones may override one another, or the parietals may override the frontal bones or the occipital bone. And the skull is misshapen. And children, when they are born, not through cesareans, by the way, if you have a cesarean, this is not going to happen. But if you have a vaginal birth, children who have undergone a vaginal birth, their skulls are generally misshapen. And mothers get afraid because they say, oh my God, my child's head is deformed. It is a natural thing that occurs, and within a day or two, as the pressure within the brain case equalizes, because of all the cerebrospinal fluid pressure, the bones reassume their normal position relative to one another, and the brain case assumes a non-deformed shape. So sutures play a very important role in the birth process of allowing bones to shift relative to one another so the child can get out of the birth canal without having these little bones. These bones are very thin. Otherwise, they'd be crushed. If they could not shift relative to one another, the bones would be fractured like an eggshell in the birth process. So the sutures have a very important role to play during birth. From birth to adulthood. Well, of course, once you're born, you don't really want to have motion between the bones of your skull. You want to have them fixed together in an interlocked way because their function after you're born is to protect your brain every time you land on your head or get hit on the head. All right. These sutures then get narrower and narrower in the first year and two after birth, and then the bones, and if you look at the skulls that you have, the bones sort of develop at the suture lines these interdigitating finger-like processes. And this is why they're called sutures. This is what they look like to somebody. They develop interlocking finger-like bony processes which lock the bones in place relative to one another. But still there's a narrow zone of connective tissue there. The bones don't fuse. These ossification centers don't fuse. They simply interlock with a narrow zone of connective tissue between them. And that narrow zone of connective tissue is absolutely essential for proper growth of the brain case. And it responds to the pressure of the growing brain within your brain case. As that narrow zone of connective tissue is stretched by the pressure of the growing brain, It grows, the connective tissue grows, and then as it grows, it becomes ossified. So the connective tissue of a suture from birth until adulthood allows the bones of your brain case, allows your brain case to expand as the growing brain expands. Otherwise, you would be in trouble. And then from adulthood on, they serve no function whatsoever. All right? You don't need, once you stop growing, you don't need to have connective tissue sutures anymore. Most people do preserve them anyway. I mean, this is not an act of will, all right? In most people, the connective tissue stays there anyway, even though it's not needed for growth. But in some people, it doesn't. Some people, the ossification centers bridge right across the suture, and the actual bones fuse. And the two parietal bones might fuse into a big giant parietal bone. But in lots of people, they'll stay separate anyway. And it makes no difference one way or the other. I don't know why some people do one and some do the other, but they do. All right, so that's about sutures. Now a little bit about the fontanelle. Fontanelle is pretty big sized when a child is born. It's called the soft spot. All right, any of you who've had children or been around newborns, you know that. It's called the soft spot at the top of the hill. It's of clinical significance because it is, number one, a signal of what is going on in the cranial cavity. If you have increased intracranial pressure for one bad reason or another, because you never have increased intracranial pressure for any good reasons, the anterior fontanelle, which is normally sort of concave, soft and concave, will bulge outward and become tense and bulged outward. And if a child presents to you as a physician and it has a bulging, outward, tense fontanelle, that's a sign of increased intracranial pressure and something you really have to deal with immediately. If a child is dehydrated, then it gets sucked in and it's tight. So if it's really sharply concave and taut, then that's a sign that the child is dehydrated, that the intracranial pressure is too low because the child doesn't have enough fluid in it. So those are things, that's why people always examine fontanelles of any child that's brought into their office. And also they examine it for size as well. Now, I expect all the medical students to memorize this chart. I don't know, Dave. Yeah, that's a joke. After the exam, you don't consider that a funny joke, I can tell you. This chart, I gave it to you. Don't even pay any attention to it. That's what it is. People have spent time. There are two. You can judge a fontanelle's size by feeling it. And after a certain point, because it gets smaller and smaller as the child grows, as the sutures get narrower and narrower, the fontanelle gets smaller and smaller. And you can judge its size by feeling it, and eventually it'll get so small that none of us would have the ability to sense it being still there. We would say that all the bones have actually met at a single point of intersection, and we couldn't feel any soft spot. On the other hand, if you took an X-ray, you might still see something there. So there's a difference between what's called clinical closure. That's when you can no longer perceive that the fontanelle is there, when you think by your fingertips that the bones now meet at a single point of intersection, and radiologic closure, which if you took an X-ray, you would see that they either met or didn't. There's a difference. I mean, the clinical, you always, when you cannot feel it anymore, it'll still be open radiologically for usually 6 months or so. But I don't care for you to remember any of that fact. You should remember, but I don't care for you to remember any of these numbers. Other than there's a tremendous amount of variation in when these fontanelles become clinically. That's from your point of view the most important. This is called clinically closed, when you can't feel it anymore. At 6 months of age, hardly you can feel it in almost every normal child. These are all normal children. These are normal children. In 6 months of age, you can feel it in almost every normal child, but in 1.7%, a normal child will have a closed fontanelle. And at 1 year of age, 30% will have a closed fontanelle. 70%, you will still be able to feel it. But there's a considerable variation in these things, and you have to live by a sort of a memorized rule, and the memorized rule is this. And this came about, in the way I even bothered to look at this chart, And I'll tell you the story. It came about because I used to teach that you should be able to feel a fontanelle until 12 months of age. And in fact, you should be able to feel a fontanelle. In most children, you will be able to feel the fontanelle to 12 months of age. You can see in 70%. You can feel it in men, and it's even more women, and 82% or 81% of young girls, you can feel that fontanelle at 1 year of age. So I used to say in my lectures, you should be able to feel a fontanelle to a year of age, and if you cannot feel the fontanelle to a year of age, your child is desperately ill. All right? I'll explain to you what the illness is in a moment. So I had a medical student who had a newborn child at about 7 months, and he goes home and he can't feel the fontanelle. And he rushes this child to the pediatrician. My anatomy professor told me that if I couldn't feel this fontanelle until 12 months of age, my child was horribly ill. And the pediatrician said correctly, tell your anatomy professor he's an idiot. And in fact, that's what made me look this up. There's a lot of variation here. The rule of thumb that you should use is if it becomes impalpable by 4 or 5 months, you should start to get worried. It doesn't mean that there's going to be something wrong with that child, because as you say, there are normal children who does become impalpable very early. But if it becomes impalpable at 4 or 5 months, you should start to think there's something wrong with the growth of the skull. And similarly, it should be gone. You should not be able to palpate it by 18 months. Because if a child is malnourished and has growth problems, the fontanelle will close later in life. So if a child's fontanelle is still palpable by 18 months, you should be worried that they have growth problems, that their growth process is not proceeding properly. All right? And so that's essentially it for fontanelle growth, fontanelle closure. Then I'll talk about what it means when it does, what a premature closure does mean near the end of this lecture. This is just one other clinically significant or relevant fact about skull growth that I want to raise now. This is an adult skull seen from an inferior view. Here's the styloid process. I know you've all read up about your skulls extensively now. And this is the tympanic portion of the temporal bone. It is the bony part of your external auditory meatus, from which where your hole in your ear goes to. And this little hole at the junction, and this bump here, what you feel behind your earlobe, if you put a finger on your skull, on your head just behind your earlobe, there's a big bump there. And that big bump, go up and down like that, you'll feel a bump. I want someone to say they feel the bump.
I feel a bump.
Thank you. It's like one of these religious tent gatherings. I need someone to testify, but I can't go on. All right, so that bump is called the mastoid process of your skull. And this little hole between the styloid process of your skull and the mastoid process of your skull is called logically the stylomastoid foramen. And it is the hole through which your facial nerve, the nerve which will innervate all the muscles of facial expression, emerges from the skull to enter the face and do the muscles of facial expression. Look at in this adult, your mastoid process is very big. Your tympanic portion of the temporal bone is fairly long, I don't know, maybe a centimeter or more. And that means if someone comes and bangs you on the side of your head like that, bang, 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 they're nowhere near your facial nerve. Your facial nerve is buried away from the lateral surface of your skull. In a child, it's quite different. In a newborn is quite different. Here's the mastoid process seen in lateral view. In the newborn, instead of there being a long tubular tympanic portion of temporal, there's a simple ring. It hasn't grown in length yet. In the newborn, there is no mastoid process. It hasn't developed yet. And when it grows, not only does it grow down, as indicated here, but the mastoid process grows outward, or grows laterally, and keeps pace with the tubular growth of the tympanic portion of the temporal bone. So as a result of having a ring-like rather than tubular tympanic portion of temporal and having no mastoid process, the stylomastoid foramen sits right at the junction of the lateral side of your skull and the base of your skull. It sits right really on the surface of your skull at that corner where the lateral part turns under and becomes the base. So this means that your facial nerve is emerging right behind your ear in a newborn. And that is the reason that you never, ever put forceps behind the ear of a newborn to assist delivery. This is automatic malpractice. Automatic malpractice, because forceps placed behind the ear crushes, very likely, the facial nerve, and then that child is left with paralysis, depending on how many facial nerves you crush, left and right, or just one of them, paralysis of their face. So you never, ever do that, and this is the reason you never, ever do that. Now, when I say the fontanelle may close prematurely, the thing I'm worried about when you cannot feel a fontanelle in a child that is 4 or 5 months or earlier, younger than that, in a newborn that's 4 or 5 infant, 4 or 5 months or younger. The thing you worry about when you cannot feel an anterior fontanelle is that the sutures are prematurely closing and fusing. And this can happen. All right? Now, sutural closure, that's something I told you normally occurs in adults and makes no difference whatsoever. That is a bridging across of the connective tissue and a merging of the bone. Sutural closure in an adult makes no difference whatsoever. There's one kind of sutural closure that is good, and that is this metopic suture. The suture between the two halves of the frontal bone, that's called the metopic suture, is supposed to start closing at about 2 years of age, and it usually fuses completely by about 6 years of age. And that is a normal sutural closure of childhood. When you look at skulls, sometimes you'll see a little bit of the metopic suture that is preserved just above the root of the nose, and I'll bring a skull into the lab and that will show you that. But normally the metopic suture closes by 6 years of age. That's fine, normal. No other suture is supposed to close before you have reached adulthood. And if a suture closes prematurely, it is called craniosynostosis. That is the condition name given to a condition where you have premature fusion of a suture. Now, this usually happens, when it's symptomatic, it's happening quite young in childhood. And so, now, there are different kinds of craniosynostosis. You can read about it in clinical sidelights. That's probably the easiest way to learn about it. I'll just say now, a simple one is one suture fusing, and a compound one is multiple sutures fusing. Doesn't make any difference. They're both bad. Multiple is worse, than one. They are both associated with cognitive disabilities in children. If it's a simple craniosynostosis, if one suture fuses, you'll read about the percentage. There's a small percent. There's not a small percent. There's a major increase, a 2- or 3-fold increase in cognitive disabilities in children born who develop this condition. If you have multiple sutures fuses, maybe a 20 or 30-fold increase in incidence of cognitive problems. And those are probably actually not related to the actual, they're probably linked to it. They don't, never mind. I'll tell you in a second. Anyway, bad sutural closure, craniosynostosis. Here is a child who has a bad sutural closure. This condition is called scaphocephaly because scaph refers to boat in Greek or Latin. It looked like a boat. I guess the head looked like a boat to somebody. It didn't look like a boat to me. But this, you can tell right away that this is not a normal shaped skull. This skull is far too narrow from side to side and is far too long and tall. So, what suture, premature fusion, would prevent growth in width of the skull? That's the first question. The sagittal suture, very good. With no sagittal suture growth, the skull doesn't grow wide because the sagittal suture is the one between the two parietal bones and is responsible essentially for all of the growth of the width of your brain case. But since this brain case is responding to pressures, the sutures which have not fused are going to try and compensate and grow more than they would. So this child has a too long from front to back skull because the coronal suture is trying to compensate and make room for the growing brain. And the lambdoid suture at the back is trying to compensate, and that will give and the squamosal suture too right here. And those two will try and compensate by growing more and give you an excessive height. So the shape is determined by failure to grow in width due to premature sagittal suture fusion and compensatory growth in the coronal, squamosal, and lambdoid sutures, and those account for the increased length and increased height. Here's brachycephaly. That's the most frequent kind, by the way. I never remember the numbers, but I usually remember it's the most frequent kind. The next most frequent kind is called brachycephaly. This child doesn't look abnormal at all, really, in this view. In this view, it looks like his skull is not long enough front to back, and it's probably too tall. And maybe in this view, you could say it's too wide. Here's another brachycephaly child, which is more obviously short front to back and too tall top to bottom. So, listen to my question, and then before you jump to an answer. Premature fusion of what suture would stop you from growing in anteroposterior length? Coronal, very good. So this is brachycephaly. It's premature fusion of a coronal suture, and you get, if we go back to this one, compensatory growth in the sagittal, which would account for a wider than normal skull, and compensatory growth in the squamosal and lambdoid, which would give you a taller than normal skull. Here is a condition where the child looks fine. When you're looking at it from the front, you look down at the top, and their forehead comes to an apex, to a peak with the skull. It's lost this entirely. Brought me one about a battery. I'm almost through anyway. So, what premature fusion of what suture would cause a very narrow forehead compared to the rest of the skull?
The metapic suture.
You're absolutely right, good. This is trigonocephaly. It's the rarest of the simple craniosynostoses and is due to a premature fusion of the metapic. Other ones, which I will not ask you to identify, but I'll tell you about, is you can have, those are all symmetric. Those are all symmetric craniosynostoses. You can have a unilateral, this person's on the left, unilateral coronal suture fusion. And so it's just this part which hasn't grown adequately in length. Here's a person with a unilateral right lambdoid premature fusion, and just this part hasn't grown properly. When you have an asymmetric skull, you do unilateral fusions of sutures as opposed to bilateral, then you get a condition called plagiocephaly. And this one, I don't care about that. This, on the other hand, is the most common cause of plagiocephaly. Plagiocephaly simply refers to an asymmetric deformity of the skull. The word means asymmetric deformity of the skull. It may be due to a unilateral coronal synostosis or a unilateral lambdoid synostosis. But most causes of plagiocephaly are kids lying always in the same sleeping position for months and months at a time. Like some kids do it, some kids don't turn over. They just lie in the same way all the time. They're interesting. And their skulls get deformed. And then generally what the physician should tell them is, my guess is that this is going to go away once they, start to sit up and move around some more and become more active when they're sleeping. And then the pressure will all equalize and it'll all come out fine. There's almost always these things correct themselves once the child starts to sit up and become more active. That is the end of this lecture.